So we're going to start this morning on a psychological note. And our title, as you can see, is Self-Evaluation and Joint Action. I mean, really, these are two talks that are on insight and metacognition. And first up is Tony David, who's Professor of Neuropsychiatry, Cognitive Neuropsychiatry at the Institute of Psychiatry, Psychology and Neuroscience. Tony's got a long career as a clinical academic, as a clinician in neurology and psychiatry, with a whole range of different interests, but I think one golden theme going throughout them has been his interest in insight, which itself is a theme he picked up on early in his research career, taking on from some of the people at the Maudsley Hospital who'd been interested in this concept right back from in the 30s and 40s. So it's a great pleasure to introduce Tony to open, and you're going to come up to the lectern.
Thanks very much. And thank you for those very nice introductions, really beautifully set the scene. So I'm going to talk about self-reflection in illness and in health. So at the biological level, knowing what's you and what's not you is absolutely essential. It helps us fight disease. It helps us manage reproduction and pregnancy. But there's also at a psychological level, as Gareth's picture slide illustrated, so that realizing that the person in the mirror, or the thing in the mirror, the animal in the mirror, is you, seems to be something that only higher primates can achieve. Maybe dolphins, there's some debate about that, but most, even lower primates, will sort of hit out at a mirror thinking it's someone else. But chimpanzees become absolutely enthralled by it and start showing off in front of the mirror. And similarly, human babies, around about 18 months, begin to realize that that's not someone else, but it's them. And we assume that that is telling us something quite deep about human capacity to self-reflect and understand itself through the metaphor of the visual, literal reflection. So here are just some random thoughts about what self-reflection is in a sort of common sense way. It's about asking yourself what sort of person you are. And you could start with something really relatively uncontroversial, although I think, as we'll probably get to hear, even that can be quite problematic. What am I like physically? Am I tall or short or fat or thin? Certainly fat or thin is quite a tendentious question. Am I dark or light? Again, not that straightforward. And even in the physical world, there's a question of how honest we are. So, you know, am I thin and that's just muscle, or am I slightly podgy? And then what am I like psychologically? Am I shy? Am I outgoing? Am I brave? Although that's more like a moral question. Am I a good person? Am I selfish? Am I generous? And how do we know we've got the right answer? What's the gold standard? Now, some people think that the question of insight into illness is something quite different from that. It's totally arbitrary, and it depends on just some authority. But really, I start with the question of going from these quite broad psychological attributes to the one where you say, am I functioning well? Am I performing well? That doesn't seem to be a long way away from saying, am I intelligent? Or am I alert today? And once you've got to that, if the answer to that question is, well, not really well, I don't seem to feel as I'm performing well or functioning well. Is that because there's something wrong with me? And again, it's not about detecting cancerous cells in one's body. It's just a feeling that one's not functioning as well as one might. And then if so, if I'm not healthy, is this physical or mental? And if I don't feel mentally well, is it that I'm having experiences that seem unusual or pathological? Do I require some sort of restitution, some sort of biomedical treatment? And that's really what psychiatrists mean when they talk about having insight. Now, you do need, all of these things, you could say, need some sort of arbitrator, some sort of gold standard against which you can measure yourself. And in terms of physical illness, it is the current biomedical knowledge that's the gold standard. In terms of psychiatry, there are those standards out there, but they're much more contested, and they are not readable off a thermometer or off an X-ray. They tend to be more based on consensus. They tend to be based on some understanding of what's rare and what's common, and on some understanding of what happens to a person with those experiences. Does it end well? But I would contend that there's nothing fundamentally different from a person asking themselves whether they feel well physically and whether they feel well psychologically or psychiatrically. Then there's the question of, well, how honest am I? How honest am I, and how honest can I be when I try to answer those questions? What am I like physically, really? What am I like morally, really, in my heart of hearts? Now I'm going to go back to this issue and the problems that poses to an experimental psychologist, let alone a philosopher. And we try and, in experimental psychology, we sort of try and get round it and look at other things that might address those questions indirectly. So here's a self-reflection or a self-appraisal paradigm. And there are many such, and there's a whole literature, and they're very respectable. You basically ask an individual to process words or pictures or other stimuli, and you ask the participant to assess them in relation to themselves. And then as a control, the same thing in relation to someone else, like a famous person, Tony Blair, or their mother or their brother. And then usually there's a very low-level baseline about making sure that the person is paying attention to whatever stimulus it is. So you can also vary the content of the stimuli. So in this case, you can have a look at how words are understood or processed. It could be positive or negative words. Does that make a difference? It could be personal or impersonal, physical or psychological. And in our case, where we're interested in insight into psychiatric or psychological problems, they might be mental illness-related words. And you can look at, you can try and get a baseline, a gold standard by asking another person to rate the individual along the same lines, rate those words, whether they apply to them. It's still not quite a gold standard, but it's one way of doing it. Or you might just look at the relative ease with which the individual themselves approaches this task. Now, this was what happened when we looked at some patients looking at those sorts of words and just asking them whether they thought the word applied to themselves and to rate that degree of ownership. And this in itself I thought was really quite revealing. So along the bottom you've got all the mental illness related words, and the way the scores are ranked. In blue are the patients that psychiatrists had deemed to have good insight on a scale. So there were generally patients who accepted they had illness and accepted their treatment and so forth. Then in the pink colour, patients, similar patients who tended to reject the idea that they had an illness and needed treatment. And then in the black were just some healthy controls matched for age and gender. So basically the blue line is higher up the y-axis, so the degree to which the person accepted that any of those, all of those words was higher than the others. But you can see there's quite a lot of up and down. So here, the word unwell is accepted more by the poor insight patients than even the good insight patients. So a word that generally suggests there's something wrong was readily accepted by the patients where there wasn't any specific mention of mental or psychological. Here's a word depressed, which was equally accepted by the high insight and the low insight patients. Again, because it seemed that that was not, for some reason, threatening or undesirable. And then here's a word, crazy, perhaps a rather pejorative term, broad term, anyway. And here you find that the poor insight patients, the patients who reject the idea they have a psychiatric disorder, really do not like the term crazy. The patients with good insight accept it along with the other slightly pejorative terms in their stride, as it were. And you can even see that the healthy people in grey, they're more likely to say, yeah, I'm a bit crazy, than a person with mental illness who's rather objects to the label mental illness. So even looking at, through this comparison, it's quite interesting to see that the person that the psychiatrist calls poor insight seems to know that there's something wrong with them, and is very selective about the way they wish themselves to be described. So this doesn't sound like it's a sort of lack of awareness at a very low level. Okay, so as Sherry has said, this first-person authority seems to go without saying, that I have privileged access to my own thoughts and feelings. Therefore, I should be the best person to judge myself. But then I would commend to you this book, Strangers to Ourselves, by some social psychologists. And they argue that actually it's through our behavior, that through our actions, that really our actions betray us, or our actions portray us in the most veridical way. And other people can observe our behavior more easily than we can. Therefore, other people actually know us better than ourselves. But clearly that can't apply to private thoughts. And what I report to you is hugely influenced by how I want you to see me, and therefore by my own values and my tendency or wish to deceive you, perhaps to deceive myself. So this is where it gets complicated. So if all we have to go on is what a person says is the results of their self-reflection, we've got to take into account that they're only telling us this, or they may only be telling us this for particular reasons. And that applies just as much to the question of whether I feel healthy or ill, or whether I think I've got a disorder or not. It's partly about what effect that's going to have by saying it. So how do we get around this? Well, one way is that if I notice an attribute or quality in someone else, then it proves that I at least understand the nature of that attribute. So if I say someone is rather selfish, and then other people also tend to say, yes, that person or those actions are selfish, then it seems that I understand the concept of selfishness. If I then fail to own this attribute in myself, which other people ascribe to me, then the question is, can this be put down to a failure of my self-reflection, assuming that I'm trying to be as honest as I can? And I'll illustrate that in relation to mental illness in a little experiment that was done. A very simple experiment using little case vignettes by Joe McAvoy, who's an American psychiatrist. So he designed these vignettes that captured various aspects of severe mental disorders, psychosis. You know, there's a vignette about a person who began to notice people talking about him. He thought it was like telepathy. They were saying very nasty things. So he was describing a sort of auditory hallucinations or thought interference that people with schizophrenia might describe. So these vignettes are given to patients and doctors, and then the experimenter asks the doctor, this person in the vignette, is he anything like the patient in front of you? And then you ask the patient, is this person in the vignette, would you say they had a mental illness? And then the patient, is that person in the vignette anything like you? So the first two questions were easy. Yes, the doctor said, that's just like my patient. And the patient says, yes, that person's probably got a mental illness. So the person understands the concept of mental illness and the symptoms and so on. Is that patient like you? No. So what have we got here? Is this a lack of knowledge? Is there a lack of self-reflection? Or some failure to, or some self-deception? Or a failure to apply the rules to oneself in the same way that would apply them to somebody else? Is it so easy to turn this spotlight of attention on oneself compared to on another person? So this was a study that we did that sort of tried to explore this a little bit further, again using vignettes. We tested the judgments made to these stories representing types of psychotic illness in patients and controls. And the hypothesis was that we were trying to tease out the ideas of explicit awareness from implicit, what the person knew deep down and what the person was prepared to say. And so we hypothesized that if the person had low explicit insight, they tended to say, no, there's nothing wrong with me, but preserved implicit insight, deep down I know I have psychological illness. They would tend to attribute mental illness symptoms to the third person, more than themselves. This was the experiment. And so vignettes were constructed like this. John is a 28-year-old man. He believes he's too easily influenced by strong-minded people. It's almost impossible to understand what he says because he jumbles up different ideas. He believes that everyone knows what he's thinking because his thoughts are broadcast like television. So these are classical symptoms of schizophrenia. And the participants were asked to rate the statements based on the dimensions of illness. Does this person have something wrong with them generally, like a mental illness? Does this person need treatment for what's happening to them? These events, these experiences of thought interference, are they in the person's mind? And then alternatively, the questions can be rephrased in the first person. If these events were happening to me, I would think there was something wrong with me, like a mental illness. I would need treatment. The experiences are in my mind. And so here's the results. You can see that the control participants in green, and the patients with schizophrenia, and up on the y-axis is a higher score means more likely to have mental disorder. So when the people were considering the vignette as it applied to them in the first person, there was no difference between the cases and controls. When the questions were phrased in the third person, the controls in the green were much more likely to attribute mental illness to them. Whereas the cases, it increases slightly, but not significantly. So in fact, patients with mental illness are very even-handed about whether those symptoms might apply to them or someone else. Whereas in fact, it's the apparently healthy, normal population that are much more likely to attribute, to pass on those sorts of symptoms to another person and call them mental illness. When they have them themselves, it's less like a mental illness. When someone else has it, it's more like a mental illness. So the controls are more likely to attribute mental illness to third versus first person vignettes. Patients are even-handed. So what's going on in patients is not an overly developed tendency to attribute things to other people rather than themselves. That's a rather normal attribute. Okay, so going back to the paradigm where you present words to individuals and ask them to appraise, there's another little tweak you can make here. I don't think I have a point now, do I? Anyway, so you can say, do any of these words apply to me? Or do any of these words apply to someone else, say Tony Blair? Just the act of asking that question of yourself has an effect on whether you're more likely to remember the word. So you're more likely to remember one of these words if you think, does that apply to me? Compared to, does that apply to somebody else? Which is quite remarkable, actually, because you're sort of doing the same mental effort, but somehow when you try and process a word or a concept in relation to the self, there's an advantage, and that's called the self-reference effect. So the self-reference effect is that encoded material in relation to self has a mnemonic advantage over the same material processed in relation to someone else. And it's thought that because the self is such a sort of strong conceptual framework within our minds, that it's sort of anything attached to it is stronger. So any memory attached to oneself sort of has this advantage. And so again, we thought that the person who finds it difficult to say they have an illness or their experiences are part of an illness may have a problem with this self structure. So the hypothesis was that patients with poor insight would have a reduced self-reference effect compared to good insight patients and healthy controls due to their poor self-reflection. And this would be especially when recalling mental illness-related words, which they would think as having nothing to do with them. So this is the results. So this is the number of words recalled, and this is the number of words recalled when you're just looking at whether they rhyme with another word. So that isn't very good for memory. You only remembered a few words like that. But there was no difference between whether you were a patient with schizophrenia who had good insight or a patient with schizophrenia who had, good insight or poor insight. Similarly, when you were thinking, does this word apply to Tony Blair, your memory was much better because you encoded that information more deeply. But there was no difference between the three groups, controls, good insight and poor insight patients. So the difference is here. This is the self-referent effect. So this is the advantage. You remembered, on average, half a word more when you tried to decide whether that word applied to you or whether it applied to someone else. And this was in the healthy controls. But there's no self-referent effect. The blue line is not higher than the green line for either group of patients. So it doesn't seem to be anything to do with whether you are deemed to have good or poor insight, but it probably does have something to do whether you have a schizophrenic illness. So perhaps that does damage one's sense of self in quite a profound way, but that's nothing to do, that doesn't really seem to affect your ability or tendency to accept the fact that you have an illness or not. So both groups of schizophrenia patients failed to show the self-reference advantage. Okay, so just a little bit of neuroscience. What happens in the brain when a person is trying to answer those sorts of questions? Am I clever? Am I nice? Am I helpful? Am I intelligent? Am I wise? it seems that we switch on this part of the brain when we're trying to answer those questions. Again, it's not about whether we're getting the answer right, whatever that right is, but it's this midline cortical system that seems to be activated in the act of self-reflection. And here's a review article showing that different kinds of experiments always tend to pick out those areas. And here's a much more formal meta-analysis where we put all the sort of imaging findings together, and the kind of average blob comes out here. So this is in the middle part of the brain, the medial frontal cortex, and this is a sagittal section of the brain. You can see that's the bit that lights up. And the experiments that show that it sometimes goes right to the back of the brain, that's found quite commonly, but it's not as commonly as the medial frontal cortex. So this was an fMRI study on patients with this paradigm. So you've seen the results of just the memory. This is actually what happened in the scanner. And what happened was that here's the bit of the brain that we're interested in, and this bit was more activated by the healthy controls, whereas the patients activated other bits that the controls didn't activate. So it's as though they're not using the parts of the brain they should be to try and answer that question. They're perhaps trying to use other bits of the brain that aren't so specialized. So this is the key area that comes out that distinguishes the patients from controls. So that the people with schizophrenia were not able to increase activation in this brain region when they were considering an attribute in relation to Blair compared to the self, whereas the healthy controls increased activation in this region when they were considering whether the word applied to them. And you can see that that's kind of quite near, though not exactly the same, as has been found in many healthy volunteer studies. So it does suggest that this brain system or an allied system may not be working optimally in people with schizophrenia. Okay, so I'm just, in the last bit of my talk, I'm just going to talk about some kind of interesting historical and recent experiments that have tried to use this in a therapeutic way. So how can we improve self-reflection? This is an admission note from Springfield Hospital back in the 1850s. It's a lady called Anne Dines who was admitted. She was a domestic servant who was admitted to a lunatic asylum. Exciting factors: disappointment in love, predisposing, hereditary. So in those days, the Bethlehem Hospital was the first port of call for people with major mental disorders. But if they couldn't do anything, they just got rid of the patients. They left uncured. So this lady spent a year at the Bethlehem and left uncured and was shipped out to Springfield for long-term care. She had a grandiose delusion that she was the Queen. Now, her psychiatrist was a Dr. Hugh Diamond, who was a keen photographer, and he liked to take pictures of all his patients, and he compiled a book called this, Application of Photography to the Physiognomic and Mental Phenomena of Insanity. So he was not entirely honest with her about why he wanted to take a photograph. I told her that it was my wish to take portraits of all the queens under my care. And she said, "Queens indeed. How did they obtain their titles? They imagined them." But this is interesting. So during the months of his care, his care, he wrote, her subsequent amusement in seeing the portraits and her frequent conversation about them was the first decided step in her gradual improvement. And about 4 months ago, she was discharged perfectly cured and laughed heartily at her former imaginations. So he's saying that having a look at the photographs with her helped her understand that this was a delusion. So What about using slightly more modern technology? What happens if you show patients videotapes of themselves when they were ill? Does that help them understand their illness? So this was a small experiment done a few years ago, and it was a controlled experiment. So patients were divided into controls and the experimental group, and the control group was shown a control video, which turned out to have been a film of Victor Borge, comedy pianist. I don't know if anyone remembers Victor Borge. Very, very funny. Nothing to do with mental disorder. Or they were shown a video of themselves. So those shown the video of themselves started off here on an insight scale and improved quite dramatically in the week following seeing the video of themselves, presumably when in rather an ill and disheveled and chaotic state, compared to just watching any old video. So the authors argued that this self-observation was actually helping insight. Problem is, we don't know whether it was watching any person in a distressed state, in a mentally disordered state. Maybe that helps. Does it have to be looking at you, at oneself? So we repeated the experiment with a tighter control, more patients, 40 patients admitted to hospital, consent was taken, a video was recorded, and then a few days later they were either shown that video or another video, but this was a pre-recorded session with a professional actor of the same sex being psychiatrically unwell, answering questions like showing that he had symptoms. So to cut a long story short, both kinds of intervention, the other person video, the self video, was associated with general improvement. So here's a depression score falling. Here's a general psychopathology score falling. This is the Insight and Treatment Attitudes questionnaire, and again, both groups tended to improve. Perhaps those watching the actor video improving a little bit more. And then in this, a more detailed insight schedule, it does suggest that those looking at the self video improved a little bit more, while those looking at the actor video actually dipped down a little bit. But in fact, statistically, none of these are significant. So both groups tended to improve on all measures, and there was no difference between looking at the self video versus looking at the other video. So what would have been a nice story hasn't really been borne out with a more tightly controlled experiment. So to conclude then, self-reflection, self-evaluation can be used as a normative construct. We can all ask ourselves those questions, and we can all be rated on how well we do. And there isn't really any reason to think that there's a categorical difference between asking some of those ordinary questions to asking whether we feel ill or healthy, which is what we talk about when we talk about insight into illness. But studying self-reflection is hampered by the difficulty in interpreting self-report. Are we really saying what we really believe? Self-reflection involves appraising oneself against representations of illness and health, which we have to make sure the person understands, as well as other people's perspectives. And it may have therapeutic implications to understand how that is performed. In terms of neuroscience, it seems that there is a cortical midline system in the brain, a part of the brain devoted to trying to answer those questions. And patients with schizophrenia, the most severe form of mental illness, who often show poor insight into their condition, seem to show difficulties or impairments in using this part of the brain. And in terms of Hugh Diamond's work with the camera and our own with video tape, literal self-reflection may aid psychological self-reflection, but the case is not yet proven. Thank you very much for your attention.
Tony. So we're going to take a couple of questions now before we move on to Nick Shea. And any questions from the floor? Okay, so we got a roaming mic, or are you going to shout? Or yeah, I think we can hear you. Yeah, if you speak loudly.
It's really interesting, the therapeutic idea. Could you just wait 1 second? You switch your mic so you can...
I don't know how you switch it on.
Well, I could hear you.
I think we're recording the session, so maybe that's...
Sorry.
Thank you, that was really interesting. The therapeutic idea was fascinating. And so is it clinically significant? And what's the longer term effects? And are you going to do more about it? Are my questions around that?
Well, the experiment showed that it wasn't statistically significant, that both kinds of intervention might have actually been helpful.
Yeah, exactly. So the other one would be maybe a bit kinder than showing people pictures of themselves not coming up their very best, if you see what I mean. So the films of the actor, you can just keep showing that to people.
Yes.
So was that effect clinically significant? And what happened in the longer term?
Well, the way the experiment was designed, there was only those two choices, and people were in hospital anyway getting lots of other treatment. And, you know, fortunately, the tendency was for them all to get better. So we don't know what would have happened in that experiment if we had a group who'd seen neither video, which would have been a better experiment, actually. But I think, you know, you've got to think that certainly when people are in hospital, in a psychiatric hospital, they're seeing other people coming in and out. And I used to sort of have a group session where people would sit round and ask each other about their illness, and I would prompt them to sort of comment on it, hopefully in a not threatening way. And I certainly felt that that was incredibly therapeutic, that patients who had begun to recover would see things in another person that they weren't able to see in themselves, and often able to give really helpful advice about it, and were completely sort of at times much less circumspect than the professionals would be when a patient said, well, I'm in hospital, there's absolutely nothing wrong with me, the police dragged me in against my will and it's an outrage. And the patients would say, now come on, face the facts, tell us what really happened. And I'll say, well, okay, I did run through the shopping centre naked at 4 o'clock, but I was under a lot of stress. And they would be challenged, again, not in a cruel way, but in a therapeutic way, to sort of just see what's been happening, what has happened to the person. And I think that was very therapeutic. So it happens anyway. This was an attempt to sort of make it a rigid experiment. But seeing people...
I was thinking about not just in hospital, because, I mean, it's very difficult to get into psychiatric hospital now with the pressures that there are on mental health services. So there's loads of other people outside of hospital who aren't getting all the other things that you're talking about, and whether that could be something useful to be done in the community is what I was already thinking.
Yeah, I mean, I think that's right. I mean, how we would do it, I don't know. But whether people do seek out images and films and pictures and representations, and when they see that, do they think, that could be me? And is that a positive thing? Or does it make them shy away from seeking help? So it could go either way.